Hi, this is Dave Kirshner, and today we're talking about lung or thoracic ultrasound. Now, in terms of an overview, we're going to be jumping all over the place, but mostly by the end of this, we want to talk about some principles of thoracic ultrasound, as well as how we're going to look at the actual lungs and what we're looking for. Now, there are 1,001 things you could look for, but let's just simplify it down into B-lines and consolidation. And the reason we look for this is when we're asking ourselves the question, well, why is this patient having shortness of breath or chest pain in the first place? Now, we're not talking about pneumothorax. We've already talked about our rule in and rule out signs previously when we covered pneumothorax. And for those of you who forgot what to look for or what they look like, the clip on the left, no pneumothorax. The clip on the right is a pneumothorax. In addition to that, we're not going to be talking about pleural effusions or hemothoraces, again, because we've covered it already. Now, this is a mid-axillary view showing the diaphragm and the liver and the good old spine sign, which tells us that we can see above the diaphragm. But enough about all these spaces around or what's happening right at that pleural line. What's going on in the actual lung itself? Well, if we want to look at the lung, first things first, let's choose a probe. We've got many to choose from. Some are going to work better than others. And it's not because of the shape or the frequency per se, but it more so has to do with the settings. So we've got to ask ourselves, well, what are the settings that are preset into the probe that we're using? And the reason for that is this. Most things that we look at with lung ultrasound are artifacts. Now, when you look at all of these, those really tiny ones may not work as well. And the curvilinear with a frequency of 1 to 5 megahertz, probably also not the best. But all this to say that know your probes, know what their settings are, so that if you're not seeing what you think you'd see, or if you're not quite getting the best image, you know how to modify it. Now, if we are going to look at the lungs and actually see something, let's think of it this way. We'll start with a lateral view of this patient. It's as though we rotated them so that they're laying down, and we put the probe right anteriorly on their chest. And this should be what we see. Now, this is a view with a curvilinear probe, and this is what it would look like with a linear probe. Now, in this clip, what I'm actually doing is I am tilting the probe side to side to show you that as you tilt the probe from side to side, you lose that bright, crisp pleural line where the visceral and parietal pleura are meeting, and it becomes more irregular. Here it is here again. And when I'm lined up perpendicular to that, you can actually start to see A lines in the far field. So we've talked a little bit about the probe we're going to use, as in you can use many of them, but know its presets. And we know that we need to be perpendicular to the pleura. Okay, that's great. But now where are we going to look? Well, this is where it gets a little difficult, especially depending on which studies you read. These are just some images that I pulled off of the internet looking at different lung zones that you can look at. You can see the pediatric one at the bottom includes a fifth lung zone, which is below the scapula, wrapping around from a posterior to a lateral aspect. The one in the upper left-hand corner is different from the one in the upper right-hand corner based on where it has the nipple or the level of T4. What all these are getting at, though, is be systematic in how you're looking at the lungs and look at as much as you can to get the best idea about what's happening in the lungs. We want to be looking at least in the anterior and the lateral views, and if the patient can sit up or roll over, it would be great to get them in the posterior views as well. So again, we're going to start anteriorly, we're going to move laterally, and then we're going to move posteriorly as well. Ideally, we'd like to get both a transverse and a longitudinal or sagittal view at each of those places. The reason is simple. In a longitudinal view, we're making sure that we have the rib in view so that we're sure that we're at the right level. In the transverse view, we're interrogating more of the lung, so we get a better idea of what's happening in the entire lung. So if you start at the top, all we're going to do is slide down in all of those views. Now we have an idea of what normal lung looks like. We have that bright white pleural line and repeating horizontal lines. And when things start to go amok, we start to see B lines. Now, just reminding you of their criteria, they have a bunch of them. and would like to hit all of them. Now, I'm sure one of you right now is thinking, but Dave, if I'm using the linear probe, I can't go all the way down to 15 centimeters. How do I know it's still a beeline? Okay, well, I guess you could switch to a curvilinear probe or a phased array to see that deep, or you could just realize that if it's already starting to erase at least one or two A-lines, you're going deep enough that you're still going to hit these criteria. Now, for those of you who haven't seen B-lines recently, this is just a reminder of what they look like. Again, they start at the pleura, they move with the pleura, they're bright white or hyperechoic, and they go all the way off the screen. Now, in this case, I'm only at 8 centimeters, but if I took it down to 14 or 20 centimeters, they would still be there. Now, another one of the criteria is that they erase A-lines. So the first thing that we can do is, mentally, we could just measure the distance from the probe to the pleural line. Repeat that, and you can see where the A-line is in this case. When you take that line away, you can see that as the B lines cross over it, it erases the A-line. So that again is hitting that criteria. Some people think it looks like a spotlight, and sometimes what can even happen is that you get so many of them that it doesn't look like a number of small spotlights, but it looks like one big one. This is a case of confluent B lines. There are so many of them packed together between these ribs that it looks like one big bright white line coming down from the pleura all the way off the screen. These clips here are just showing again the pathologic finding on the left from the normal lungs on the right. Not to oversimplify it, but I do tend to think of it as from everything going horizontal in normal lungs to things going vertical or at least irregular in abnormal lungs. Now, B-lines themselves, all that tells you is that there's a density within the lung. It just means that there's something that's packed closer together that's leading to this artifact. And the differential is a little longer than we'd sometimes like to think. Okay, this is the point where you pause this and write these down, if you're type A. Okay, now, everybody's back. Half of you stopped and paused it, the other half didn't. Good job to you. But these are the ones that we tend to think of when we see B-lines. And obviously, when we put together the clinical picture, we get an idea of which one is more likely. So maybe with our clinical case, we can even narrow it down to 2 or 3 of these out of the 8 that I have here. The other way that we can think of B-lines is where are they located. We could put that into a table format. Again, someone's going to pause it and write this down if you want. And it's just looking at where we would see them. Is it going to be more diffusely or more focally? Now, in things like ARDS, I'll let you know, you tend to see them diffusely, but in little pockets everywhere, if that makes sense. And then obviously also knowing that if you have one neoplasm versus multiple, if you have diffuse alveolar hemorrhage versus localized, or multiple contusions or infarctions versus just one, they can vary in their location. And it really is all just along a continuum. Now, that being said, if we're going to say, okay, I'm just going to slide down anteriorly and laterally and posteriorly as well, and I'm looking for B-lines, and based on where I find them, I'm going to make a diagnosis, I got to tell you, that's not the way that I think we want to do it. I realize that some of the lung specialists who have done hundreds, if not thousands of scans support this. I think it's still safer to get a broader picture. Now let's say we take this lady just to be B-lines. If we're just going to look at this, we're only getting part of the picture. We really need the whole picture to know if our patient really is in danger or not. And that's why I say if you're seeing only B-lines, you need to look at the heart and the IVC. And what I mean by that is if we're looking and we're seeing B-lines as the only abnormality on our ultrasound screen, and we're not seeing any other changes like subpleural lesions or irregularity in the pleural line or pleural effusion, then we really need to look at the heart and IVC as well to know that we're not missing anything or making an incorrect diagnosis. So again, the take-home point from B-lines is that there is a differential diagnosis, know the criteria for them, think about where they're located, and when you see them, think, well, do I need to look somewhere else as well? Okay, with that being said, let's move on to something that I love looking at, and that's looking for pneumonias. We're not going to be getting into the data in terms of, well, is this a viral pneumonia? Is this a bacterial pneumonia? Are we talking about pediatrics? Are we talking about adults? What we're looking for in this next little bit of discussion is the lobar pneumonias, the ones that if you got the x-ray, you'd be like, hey, that's a giant lobar pneumonia. When we're actually discussing this when we get together, we'll talk a bit more about the nuances. But again, if we're thinking big lobar pneumonias, this tends to be the way that they progress. You start with B lines as you're starting to get a little bit of pus and junk in those intraalveolar spaces, and it tends to accumulate more so at the periphery, or right at that visceral pleura. That in turn leads to inflammation and infection, which leads to an irregular pleural line. If this process continues, you get into these subpleural lesions, which are a little bigger. Some people also call them subpleural consolidations. And finally, you can get full hepatization of the lung, or when the lung looks like the liver. And then you may also get effusions as well. So B lines, irregular pleural line, subpleural lesions, and finally hepatization plus minus effusions. Okay, so surprises, surprises, we're looking at another lung. Let's go through that. Okay, we've got some B lines in this case. We can see these bright white lines starting at the pleural line. They're going off the screen. I'm not seeing any A lines, which means if I'm perpendicular, I must be erasing them. But in addition to that, the next thing we can ask is, well, do I have a straight and crisp pleural line where the visceral and parietal pleura are meeting? What do you think about this case? I think the answer is no. I don't think that this is a crisp pleural line. I think it's irregular and there's something going on there. It's going to be for one of two reasons. The first reason would be that my angle's off, which is something that we talked about at the beginning of this lecture. So I might need to tilt side to side to confirm that I am as perpendicular as I can be. If that's not the case, then what I am starting to see is either inflammation or infection right at this pleural line where the visceral and parietal pleura are meeting. This is another example. In this case, let's ask those same questions. So first off, we've identified our ribs and our bright white pleural line. Then I ask myself, are there any B lines coming off of the pleura? In this case, there does seem to be B lines, but they don't seem to be coming right off the pleura. They seem to be coming off of this subpleural lesion, which looks like the hypoechoic area. It's almost as if someone took an ice cream scoop and they scooped out part of the pleura there, and then you had B lines behind it. There's actually nothing missing there, but that area that looks scooped out actually is filled with fluid, whether that's pus, blood, fluid. It's filled with something, which is why we can see through it. And then where it meets the normal aerated lung posterior to it, that's where we're seeing the B lines, and then down to, we can't even see the normal lung behind that point. Of note as well in this case, that's the subpleural lesion and the B lines. We can actually see an A line right there that keeps getting erased every time the patient breathes in and out. Here's just one more example of one of these subpleural lesions. So again, we've identified our ribs and our pleural line. We don't have any B lines coming down from the pleura, but we do have this subpleural lesion with B lines coming off of it posteriorly. And that's seen right here, and again the B lines. Now I know I said that we'll go normally in a bacterial pneumonia from B lines to pleural irregularity to subpleural lesions to hepatization. It doesn't always follow this nice step. Like in this case, we've got an area that looks like a problem or of concern, but we don't have B lines surrounding it. I wish I had a good reason for you why that's not always the case, and again, it's something that we'll discuss a little bit further when we get together. Now, let's say that this gets so far gone that this subpleural lesion area, this part that looks like it's scooped out with an ice cream scoop, got a lot bigger. This is what it might look like. Now already you might be saying, well, Dave, I'm not sure what we're looking at. Okay, let's find our landmarks again. We've got skin and subcutaneous tissue. We've got a rib that's just off screen right, and one that we're just partly seeing on screen left, and just deep to them is this pleural line right here. Now, does that pleural line look bright white and smooth? And the answer should be no. We see a very thin pleural line there, but we're also not seeing anything else that we'd expect if this were a normal pleural line. We're not seeing repeating A lines. Instead, what we're seeing is this hypoechoic area with these areas mixed in it, this hypoechoic area with these hyperechoic areas mixed into it. And that's what a focal consolidation looks like. It's hypoechoic because it's filled with fluid or pus and junk there, and it has these small bits of hyperechoic tissue, and that's where the air is. It's bordered posteriorly or deep by something called a shred sign. And this is where you have B lines that are going from where the lung is completely consolidated to normal lung behind it. Now, I said that we went from B lines, pleural irregularities, subpleural lesions, to hepatization. This next one here is the right lung taken from a mid-axillary view. I'm just going to let it loop through a couple times. But this person also had a lobar pneumonia in their right lower lobe. Just to orient ourselves to a little bit of anatomy here, we've got the liver, and we've got the diaphragm actually a little bit higher than where I stopped it there. And this area above, this is lung. It looks as though to be almost the same echogenicity of the liver, which is why we call it hepatization. We can also see that we're seeing the spine above the diaphragm, which tells us that there's a density above it. In this case, it's not fluid, it's lung. This is a lobar pneumonia that's sitting right on the diaphragm and above the liver. So this might be the patient that comes in with a cough, fever, and belly pain because it's irritating the diaphragm. Okay, so we've gone through all that. I just want to show you a couple more things that go along with pneumonia that you might see. One of them being dynamic air bronchograms. Now, this is another lobar pneumonia. Pretty much this whole thing that we're looking at is a consolidated infected lung. And you might be able to see in about the middle of the screen there are these bright white bubbles, circles that are moving up and down. And those are called dynamic air bronchograms. And those are telling us, or actually what we're seeing, are small bits of air moving through the actual bronchioles. This tells me that it's not atelectasis because I wouldn't see air moving if this were atelectasis. There are a couple other things on the differential diagnosis when you see a big consolidation like this, and seeing these dynamic air bronchograms really helps us know that we're working with an infection in the right clinical setting. This is just another example. If you just have another look, you're going to see some dynamic air bronchograms right down here. Sometimes they're out from behind the rib, other times they're not, but you can see that they're moving along those little bronchioles. Now I show them compared to these, which are static air bronchograms. These bits of air here are still within lung, that's consolidated. This is actually taken on the left side. This is a left lower lobe pneumonia. And this is air that actually isn't moving through the bronchioles. It's just staying right in the bronchioles. And the reason it looks like they're moving is that the patient's breathing. If you see dynamic air bronchograms, we're working with a pneumonia. If you're seeing static air bronchograms, you may be working with a pneumonia, but it could also be atelectasis. The case that I think about this the most is in pediatric patients. When you're wondering if it's a pneumonia or atelectasis and you see static air bronchograms, oftentimes I'll give them 8 puffs of Ventolin or salbutamol, come back in an hour, see if this is opened up at all. If it's still there, I'm more concerned that it's pneumonia. If it's cleared, it was probably atelectasis to begin with, and now it's resolved. This next one, a pediatric patient, just because they gave a good image, is showing now a consolidated lung with an effusion as well. And I have some words on there just to orient you, but also just to let you know that that's the lung, the liver, The heart's back here that you'll see, and then they actually have this giant effusion right here. And this really isn't a great fusion at all. This was a child that wasn't immunized that had a strep pneumonia, and you can actually see that there's fibrin starting to form there. So this is when pneumonia gets really bad, and now it's getting into a complicated one. So briefly, we've gone from normal lung that we can see in the left upper side to B lines with some pleural irregularities, all the way down to a consolidation or subpleural lesions, and moving on to a consolidated lung with a parapneumonic effusion as well. As I mentioned, it won't always go from A to B to C to D. Sometimes it'll go right A to C or A to D, depending on the pathology and the organism causing that. Now, it'd be amiss if I told you that anything that looked like a consolidation or subpleural lesion was actually a pneumonia. There is actually a differential, and these are the ones that I want you to think of: pneumonia, atelectasis, malignancy or mass, infarcted tissue, and thymus. And the reason for that is simple. These are both subpleural lesions with maybe some B lines surrounding them, but I'll tell you that the clip on the left is a lung mass in a smoker, and the clip on the right is infarcted tissue post-PE. And they both look very similar to those pneumonias that we were seeing. So we need to keep our clinical context in mind, and if something isn't making sense, go for further imaging. This is an example, and it was one of the other things on the differential, of what the thymus looks like. Here we have a rib, still cartilaginous, and right here is the thymus. Now, with all that done, let's just go through a couple cases. So this is a case of a 14-year-old girl sent in to see you from her family doctor. She had a chest x-ray done 3 days ago. She'd been started on azithromycin, and he sees her today, and he gets a repeat x-ray, and he says, you know what, she's not doing any better. Look at that. She needs that tap because clearly she has a pleural effusion now on that right side. If you look carefully, you might say, well, there's really no meniscus there. It seems to be sloping down as opposed to upward, like I'd expect an effusion. And there are maybe even a couple air bronchograms. But this is an iffy one. However, if we put our abdominal probe in our mid-axillary line just at the level of the diaphragm, so the diaphragm's in the center of the screen and the marker's pointing towards her head, this is what we see. We can see the diaphragm and the liver, and we can actually see the spine here continuing above the diaphragm. So is this an effusion? Well, although it does look hypoechoic, it does have those hyperechoic areas within it, and they almost seem to be branching. And that's actually air within the bronchioles. So this is not a pleural effusion. This is a lobar pneumonia that's just really dense. You can continue the antibiotics or change them if you want, but she doesn't need a thoracentesis for this. Now, interesting note, and I'm not bitter at all, she was admitted, and they didn't believe me, so they got the lateral decubitus x-ray the next day. That's what this is. And suckers, it showed what I already knew. Boom, roasted. Okay, next case. You're seeing a gentleman, mid-70s, and he's coming in with shortness of breath. And you look at his old x-rays, and they say that he has a pleural effusion there, and you get this image, and then you get the formal report, which says a moderately large right-sided pleural effusion is seen with atelectasis or consolidation in the base. Okay, so I know I said that we weren't going to really talk about pleural effusions, but I couldn't let this one go, just because it had so many smaller teaching points. So this patient, when I saw them, I thought, well, I've got to know what I'm looking at. I'm going to put the probe on. And so I put the curvilinear probe, mid-axillary line, trying to get the diaphragm in the middle on the right side. And this is the view that I got. So do you think that there's fluid there to tap, yes or no? And this one's a little tough to orient yourself. In the near field, we have skin subcutaneous tissue. Then we have this big area of blackness or anechoic fluid, which we think there might be something in there. A little bit to the right is the diaphragm that looks flattened. And then in our far field, we have the spine. Well, I wasn't sure if I really wanted to go in and poke this, and I thought, well, it could be pneumonia, and maybe this is a parapneumonic effusion. But why don't I have one more look at it? And when I had one more look, I actually had the phased array probe. And this is the exact same position on the same patient 15 minutes later. Now do you want to poke this? Pause for effect. I hope the answer is no. So this is actually what it looks like when you get a completely loculated pleural effusion on ultrasound, taken in the same spot as that last one. And I know I was bugging everybody before about why are we using this probe or that probe and what are the settings. And the reason is shown between these two clips. And if I put them just kind of the first and the second on top of each other, there are a couple things that are different on the machine that are telling us why they look so differently. First thing I wanted to bring up is compound imaging. And although the top one's using the abdominal probe, or the C2 to 6, and the bottom one's using the phased array, the frequency that they're using is about the same. 4 megahertz and 3.5, they both have harmonics on, but the one at the top has that little C, which means compound imaging. And how compound imaging works is it's trying to clean up the picture to make it look nicer by getting a couple more views of whatever you're trying to look at. That's hard to conceptualize, so just have a look here. So you have your ultrasound probe, you're trying to look at this vessel per se, and if you don't have compound imaging on, these are the ultrasound beams that are coming out. They're going straight down and then they're bouncing straight back up if they're not hitting anything to send them off to the side. And you'll get an idea of what that structure looks like. When you press the compound imaging button, which we can on some machines, it's also taking sound from this angle as well as this angle, and it's putting it all together to try to make a smoother picture. In doing so, it gets rid of some of the artifacts that we're looking for, and it tries to smooth everything out. Obviously, this takes a little bit more energy as well and a little bit more data inputting. And so the other thing that it changes is your refresh rate. And again, if we look at that top and the bottom one, the top one's at 10 and the bottom one's at 27. All this means is that on the top image, you're getting 10 images per second really, and the bottom one, you're getting 27. So that's why the bottom one doesn't look as choppy, and the top one does look choppier. So again, I bring this up because you might see some effusions that look like this when you get a pneumonia, and also just to remind you of what probe you're using and what settings you're using when you're looking at some of these things in the lungs. Okay, so that was the second case. It was a little longer. Third case, I'll just tell you, you've got a gentleman who comes in short of breath. And wherever you look in, whether it's his right anterior side or his left anterior side, these are the views that you're getting. I'll say that he has, let's say he has a history of CHF and COPD, and otherwise everything else is normal. Is this enough to tell you if it's going to be, like a viral pneumonia or decompensated heart failure? Probably not. In this case, we need more information. If we're just using this when they have a complicated picture and we're just seeing B lines, we need to look for more things. We need to look at more lung fields, and we should also be looking at the heart and IVC as well. And we go over some cases when we meet. That's what we'll do. And with that in mind, these are the take-home points really. We need to have a differential diagnosis for B lines. We need to have a thought about how bacterial pneumonia might progress, differential diagnosis for focal densities, and then also consider the settings of our machine, especially if we're not sure what we're seeing. Thanks, everybody.